Interesting question. So we have studied that in pancreatic neuroendocrine tumors. We used a large data set at the Mayo Clinic to look at that. We were not able to find anything that predicted NETs. We know that for small bowel neuroendocrine tumors, we know from large population studies in Sweden, there may be a low familial risk. So I would say all patients who have either have a first-degree relative, a parent, or a child, or a sibling with the NET should seek out one of these medical centers that are actually studying familial NETs, including the NIH and the University of Iowa. And as for other risk factors, we don't know. They're becoming more common, partly because we're better at diagnosing them, but also I think because they're just becoming more common. And we have essentially failed to identify risk factors. It's a hot topic. I would say for most NET patients, biomarkers add little. And there is a lot of disagreement even within the NET circles. There are biomarkers that predict outcome and some that may even predict responses to therapy. And there are some that may have diagnostic value. The most commonly used one is chromogranin. It has such severe limitations for most parts that we can't rely on it for diagnosis, and we can't really rely on it for treatment decisions. There are other markers, including a marker called pancreastatin, which was discussed at a couple of posters here, that may have some better, more reliable characteristics than chromogranin A, and then there are some novel genomic markers that have been studied and look promising, but essentially larger studies are needed. What we need to know is really we need to do studies that confirm that or refute that these markers actually change treatment decisions and eventually change outcomes. If the marker is not going to change the outcome, I don't think we should do it.